Thank you for allowing me to be here. Thank you for thanks for the opportunity to talk today. Yep, there we go. So we have no conflicts of interest to disclose, although this work was graciously supported by SAGE's grant funding to myself and Dr. Tellum, as well as R01 funding from the NIDDK to Dr. Tellum and, excuse me, Dr. Rubion. So it's no secret that the robot has seen rapid adoption within general surgery over the last several decades, and really there's nowhere more apparent than within ventral hernia repair, which has seen a 45-fold increase in the proportional use of robotics just from 2012 to 2018 alone. However, controversy exists over the incremental value added by the robot for ventral hernia repair, and really current data is mostly limited to short-term outcomes. An important but understudied area where the robot may actually provide some benefit is within patient-reported outcomes, or PROs. So existing literature on PROs after robotic ventral hernia repair is largely limited to 3 randomized control trials and 2 observational studies. And they carry with them some important limitations. So first, we really lack population-level data, so most studies really come from 1 to 2 institutions. Again, most focus on short-term patient-reported outcomes, so those measured at 30 days or 90 days, and we have very little long-term data. And then last, the majority really only include high-volume, experienced, minimally invasive surgeons. So this doesn't represent the variety of training and practice patterns that you see across the country for the majority of surgeons who perform hernia repairs. So this led to our main study objective to evaluate how long-term PROs differ after robotic, laparoscopic, and open ventral hernia repair in a population-based statewide registry. So our data source was the Michigan Surgical Quality Collaborative Core Optimization Hernia Registry, or MSQC Core. This was established in January of 2020 and encompasses 68 Michigan hospitals as well as over 15,000 ventral and incisional hernia cases. The registry collects population-level nuanced patient hernia and operative characteristics, also collects 30-day outcomes in addition to 1-year PRO data, and data is abstracted by professionally trained nurses and audited annually for accuracy and quality. So for our study population, we looked at all patients undergoing ventral hernia repair from January 1st, 2020 to September 30th, 2022 in the core database. And patients were surveyed 1 to 2 years postoperatively by text, email, or phone with regular reminders. And we looked at 3 main instruments. So first, many of you are familiar with these instruments, but the ventral hernia recurrence inventory. So this is a 3-question validated tool with up to a 96% sensitivity for clinical recurrence and encompasses the following 3 questions. Do you feel your hernia has come back? Do you feel or see a bulge? And do you have pain or symptoms at the site? Next, we look at the PROMIS Pain Intensity 3A or Pain 3A score, which again is a validated 3-question set of in the last 7 days, how intense was your pain at its worst? How intense was your average pain, and what is your level of pain right now? Those scores are then summed up and converted into a T-score to compare to the average U.S. population, and given skewed responses towards less pain in our sample, we further dichotomize this variable to a worse than average Pain 3A score. And then lastly, we looked at the Hercules Quality of Life score, which again is a validated 12-question tool aimed at assessing abdominal wall functionality. The composite score is normalized to a 100-point scale, and given skewed responses towards high quality of life, we further dichotomize this to a below median Hercules score. So for our analysis, we looked at a few primary outcomes, answering yes to each of the 3 VHRI questions, as well as reporting a worse than average Pain 3A intensity score. And our secondary outcome was reporting a worse than median Hercules quality of life score, and this was because we had fewer complete responses due to the number of questions, as well as no preoperative baseline data. Because it's survey data, we did employ non-response weighting schemes and ranking schemes to balance respondents with the non-respondents, as well as with the overall core population. And then we use multivariable logistic regression for each outcome, controlling for patient, operation, and hernia-specific characteristics. And then given the known limitations of reporting odds ratios from particular studies, we calculated the average marginal effects or the predicted probabilities for each approach. So in total, we had 1,583 patients with complete VHRI and Pain 3A data. 507 of these were performed robotically, 202 were laparoscopic, 874 were open. This represented 68 hospitals and 337 surgeons in the state of Michigan, and the median follow-up time was 1.3 years. In the interest of time, I'll skip over some of the baseline demographics between groups, but kind of the notable differences: the robotic group had slightly larger BMIs, were more likely to be elective, and had fewer small and more medium-sized hernias than the lap and open groups. The laparoscopic group, as expected, had very few myofascial releases and the open group had more umbilically located hernias, had a lower mesh use rate, and a higher complication rate than the lap and robotic groups. So now you'll see our results after survey weighting adjustment and multivariable regression adjustment. The error bars represent 95% confidence intervals. So for VHRI question 1, we found no difference by approach in the predicted probability of reporting hernia recurrence. However, for VHRI question 2, we actually did find a slightly lower predicted probability of reporting a bulge in the robotic group when compared to the laparoscopic group. However, no difference was found when comparing the robotic group to the open group. For VHRI question 3, we found no difference by approach when comparing the predicted probability of whether someone reported physical pain or symptoms at the site. And then looking at the pain 3A scores, we found no difference by approach in reporting a worse than average pain intensity score. And then finally, looking at Hercules scores, we found no difference by approach when looking at the lower than median Hercules quality of life score. So in conclusion, 1 to 2 years after ventral hernia repair, a robotic approach was associated with a decreased likelihood of reporting a bulge than laparoscopy, but equal likelihood when compared with an open approach. And no other differences were found by approach for patient-reported hernia recurrence, pain and symptoms at the site, overall pain intensity, or quality of life. So our study has a few limitations. First, it's an observational study, so it's obviously prone to unmeasured confounding or selection bias. We did control for patient hernia and operative characteristics that are not available in claims data. And while not perfect, it is the first population-based analysis of long-term PRO, so it really reflects the real-world practice of surgeons in Michigan. Second, because we use survey data, it's always at risk of recall and response bias. We did use validated instruments to try to mitigate this, as well as survey weighting schemes. However, our Hercules data is limited by the lack of baseline scores and more missingness. And then finally, we may be underpowered to detect small differences by approach. However, our study does contain more long-term PRO data than all other published studies combined, and we continue to collect data on a rolling basis. So what do we do with all these data? Well, I think one side, you could say equivalent or slightly better long-term PROs is a positive, and that this rapid adoption has really not been shown to harm patients. And on the other side, you can say that equivalent or slightly better long-term PROs is a negative, as it potentially brings about questionable value added when considering the increased OR time and costs of the robot. I believe a middle ground is probably the best place to be, and that we really need further work to understand and leverage the true benefits of the robot. Some of those areas might include robotic component separation, which offers us a minimally invasive approach to a very complex repair, and it's shown good outcomes in recent data, as well as some of the practical benefits that we need to consider. So, surgeons without assistance gaining extra arms in the OR, or perhaps the benefits of the dual console when teaching trainees. But realistically, we need further work to understand the learning curve of robotic ventral repair, and this will inform opportunities for more intentional credentialing and training in the future. A big thank you to SAGES and to Dr. Tellem and the Core Lab team, and I'm happy to take any questions.